Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 513 of our pharmacotherapy series, which majors in chronic kidney disease. The first case reads, HBT is a 65-year-old white man with category 5 CKD who has just started chronic hemodialysis. He comes in today for his third hemodialysis session. Dialysis scheduled 3 times a week, 4-hour duration. He has a history of hypertension, which has been poorly controlled during the past 4 months. Blood pressure ranges 150 to 190 systolic and 85 to 105 diastolic, and has experienced shortness of breath and a significant weight gain during the past month. His pertinent medical history includes hypertension for the past 14 years. HBT's current medications include metoprolol tartrate 50 mg twice daily, furosemide 80 mg twice daily, calcium carbonate 500 mg thrice daily with meals, and nephrocaps 1 by mouth, i.e. orally, every day. HBT's most recent pre-dialysis blood pressure was 195 systolic, 100 diastolic, and his post-dialysis blood pressure was 168 systolic, 90 diastolic. A recent ECG showed evidence of left ventricular hypertrophy. Pre-dialysis laboratory values were as follows. Serum sodium levels of 140 milliequivalents per liter. Potassium levels of 5.1 milliequivalents per liter. Chloride levels of 101 milliequivalents per liter. Bicarbonate content of 23 milliequivalents per liter. Serum creatinine of 8.8 mg per deciliter. BUN of 84 mg per deciliter. Phosphate levels of 6.5 mg per deciliter. Calcium levels of 8.6 mg per deciliter. Serum albumin levels of 3 grams per deciliter. Cholesterol, non-fasting, of 345 mg per deciliter. Triglycerides of 285 mg per deciliter. Transferrin saturation of 18%. Ferritin of 250 nanograms per milliliter. A hematocrit of 27%. A hemoglobin of 9 grams per deciliter. HBT has a urine output of 50 milliliters per day. So my first question to you reads, what conditions evident in HBT place him at increased risk of cardiovascular complications and mortality? HBT has uncontrolled hypertension that is not adequately managed with his current drug therapy or hemodialysis. Hypertension is associated with left ventricular hypertrophy, ischemic heart disease, and heart failure, all of which are contributing factors to overall mortality in patients with CKD5D who are undergoing dialysis. HBT's ECG evidence of left ventricular hypertrophy should trigger additional evaluation to determine the extent of cardiac involvement and diagnosis of heart failure, which is associated with increased mortality in both diabetic and non-diabetic patients. Left ventricular hypertrophy develops early in the course of CKD and progresses as kidney disease progresses. HBT is in the most severe stage of CKD and has the greatest likelihood of developing left ventricular hypertrophy. Anemia contributes substantially to the development of left ventricular hypertrophy and heart failure as well. HBT's hemoglobin of 9 grams per deciliter is below the target value and requires treatment based on evaluation of his iron indices. Additional factors that increase the risk of cardiovascular complications and mortality in HBT include elevated cholesterol and triglycerides levels as well as hypoalbuminemia, serum albumin, 3 grams per deciliter. Increased levels of homocysteine are common in patients with kidney failure and have been associated with increased risk of coronary artery disease. Because elevated concentrations of homocysteine have been observed in conjunction with decreased folate and vitamin B12 levels, more aggressive supplementation of these vitamins in this population has been suggested. Because patient HBT's total corrected calcium, corrected for hypoalbuminemia, is 9.4 mg per deciliter, his calcium and use of a calcium-containing phosphate binder will need to be monitored frequently. Cardiac calcification is common in patients with kidney disease and also is associated with cardiovascular complications. It has been reported that approximately 80% of patients with end-stage renal disease have detectable coronary artery calcification. Cardiovascular disease and complications continue to be the leading cause of mortality in patients with kidney failure. My next question to you reads: what options are available to treat HBT's hypertension considering his other cardiac complications and blood pressure goal? I will now briefly comment on dialysis. Hypertension is common in patients with CKD. Multiple factors are involved in the development of hypertension in the CKD population, including extracellular volume expansion from salt and water retention and activation of the renin-angiotensin-aldosterone system. Additionally, the increase in uremic toxins leads to sympathetic nervous system stimulation and elevation of blood pressure. Because patient HBT is just beginning dialysis therapy, it is difficult to assess the degree to which volume removal will ultimately affect his blood pressure. To control blood pressure related to volume changes, dialysis therapy should be adjusted as needed to achieve patient HBT's dry weight, the post-dialysis weight at which symptoms of hypovolemia and hypovolemia are absent, i.e., normovolemia and free from edema. Patient HBT has had recent findings consistent with worsening volume status, shortness of breath, weight gain, that should be considered when modifying his dialysis prescription. Further workup is needed to determine whether patient HBT has systolic or diastolic heart failure. It is also important to counsel patient HBT on the importance of salt and fluid intake restriction between hemodialysis sessions to minimize weight gain, volume expansion, and hypertension. Restriction of salt intake to less than 2.4 grams per day and fluid to 1 liter per day is appropriate and will require regular follow-up by a dietitian. Next, I will briefly look at antihypertensive therapy. Currently, There are no published guidelines for the management of hypertension in patients receiving hemodialysis. Although there are no published guidelines, control and management of hypertension is important. Antihypertensive therapy should be used in conjunction with dialysis therapy in patient HBT to target blood pressure. In the absence of published guidelines, targeting a blood pressure of less than 150 systolic 90 diastolic before hemodialysis is reasonable. For some patients, initiation of dialysis alone may achieve this goal, and antihypertensive therapy may be withdrawn. The aim of the blood pressure goal in patients with CKD5D is to minimize cardiovascular complications, but it should not increase the risk for hypotension and its associated complications during dialysis. The choice of an agent is based on the patient's comorbid conditions because no single agent has a consistently proven mortality benefit in patients on hemodialysis. The complexity of managing hypertension in patients on hemodialysis is enhanced by the apparent U-shaped relationship between blood pressure and mortality. A study of patients on hemodialysis found an increased risk of cardiac-related death at a systolic blood pressure less than 110 mm of mercury and at a systolic blood pressure greater than 180 mm of mercury. Another cohort study found a systolic blood pressure between 100 and 125 mm of mercury was associated with the lowest risk of death, and systolic blood pressure above 150 mm of mercury associated with increased death. The mortality risk with a low pre-hemodialysis blood pressure may be indicative of severe cardiac disease at the initiation of hemodialysis. If patients experience hypotensive symptoms during hemodialysis, the goal blood pressure can be increased, but they also should be evaluated for other cardiovascular disorders. Because the blood pressure between dialysis sessions varies owing to volume changes, the ideal time to measure blood pressure relative to dialysis, i.e., pre-dialysis versus post-dialysis, is unclear, but pre-dialysis blood pressure has been favored. Diuretics are commonly used in patients in the early stages of CKD. As discussed previously, the effectiveness of diuretics depends on the amount of sodium delivered to their site of action in the kidney tubule and on the patient's kidney function. For example, a decrease in the eGFR from 125 to 25 ml per minute per 1.73 meters squared, theoretically, could result in an approximate 80% decrease in the amount of sodium filtered. Early in the course of kidney failure, thiazides or thiazide-like diuretics are effective antihypertensive agents. As eGFR is further reduced, that is eGFR below 30 ml per minute per 1.73 meters squared, the thiazide diuretics become less effective. Potassium-sparing diuretics are also ineffective and may increase the risk of hyperkalemia. Loop diuretics, e.g., furosemide, which function more proximally, are indicated in patients with CKD4, that is eGFR 15 to 29 ml per minute per 1.73 meters squared. These drugs can be effective for blood pressure and volume control in patients with advanced kidney disease if residual kidney function is substantial, urine output above 100 ml per day. Their effect must be frequently re-evaluated on the basis of urine output and any effect on volume control. Patient HBT's urine output should be assessed to determine the rationale for continued use of furosemide, and the current dose should be assessed because doses higher than his current dose of 80 mg twice daily are often required in patients with this degree of kidney dysfunction. It is likely that furosemide will need to be discontinued as patient HBT's residual kidney function declines. Given the role of the renin-angiotensin system in the development of hypertension in patients with CKD, angiotensin-converting enzyme inhibitors are a logical choice for antihypertensive therapy. Angiotensin-converting enzyme inhibitors are effective antihypertensive agents in patients with CKD and have been shown to reverse left ventricular hypertrophy. Angiotensin-converting enzyme inhibitors are underused in this population. Response must be assessed individually to determine whether renin-angiotensin-aldosterone activity is a predominant etiology of hypertension. Initiating therapy with low doses is prudent to evaluate patient response and tolerance. Use of these agents in combination with other antihypertensives is often required for adequate blood pressure control. Most of these agents can be administered once daily. However, because of the kidney elimination of the parent drug or active metabolite, dosage adjustments are necessary in patients with CKD. Angiotensin-converting enzyme inhibitor use should be avoided in patients undergoing dialysis with the polyacrylene I-trail, also known as AN69, membranes. The polyacrylene I-trail dialyzer increases bradykinin production, whereas angiotensin-converting enzyme inhibitors decrease the breakdown of bradykinin, predisposing patients to systemic or immune-mediated reactions that can lead to anaphylactic reactions. Angiotensin II receptor blockers effectively lower blood pressure and reverse left ventricular hypertrophy in patients without kidney disease. These agents offer an alternative to angiotensin-converting enzyme inhibitors in patients experiencing kinin-mediated adverse effects. However, similar side effects have been reported with angiotensin II receptor blockers. Beta-adrenergic blockers, also called beta blockers, inhibit release of renin and may be useful in hypertension associated with CKD. Beta blockers can counteract the elevated sympathetic activity observed in dialysis patients, lower the risk of sudden cardiac death, and improve survival in heart failure. Unfortunately, they are underutilized, and the mentioned benefits are understudied in the dialysis population. Risk versus benefit should be evaluated when beta blockade is considered in conjunction with other comorbid conditions such as asthma, heart failure, and lipid abnormalities. Dosage adjustment is required for the less lipophilic agents, i.e., atenolol, nadolol. Calcium channel blockers are effective antihypertensive agents in patients with CKD. Because the non-dihydropyridine agents, i.e., diltiazem and verapamil, have negative chronotropic and inotropic effects, they should be used with care in patients with heart disease. Generally, dosage adjustment is not required in patients with kidney disease. Other agents used to treat hypertension in the CKD population include centrally acting agents, e.g., clonidine, or methyldopa, vasodilators, e.g., minoxidil, and hydralazine, and alpha-1 adrenergic blockers, such as prazosin, terazosin, and doxazosin. However, these agents are generally reserved as last-line therapies. Patient HBT is currently taking the beta blocker metoprolol and the loop diuretic furosemide. Metoprolol is a beta blocker considered to be removed by dialysis and should be monitored closely for patient HBT clinical response to the therapy while starting dialysis. It is likely that his diuretic will need to be discontinued as his residual kidney function decreases and response to therapy is inadequate. If changes imposed in patient HBT's hemodialysis prescription are able to improve volume control and achieve his dry weight, but do not reduce his blood pressure, another antihypertensive regimen should be selected. A reasonable antihypertensive regimen would include an angiotensin-converting enzyme inhibitor, e.g., ramipril. The selection will depend substantially on follow-up results of his cardiac disease, blood pressure control with hemodialysis, and the development of adverse effects. My next question to you reads: how should HBT's lipid abnormalities be treated? Patient HBT has elevated serum cholesterol and triglyceride concentrations, a common finding in patients with CKD. Dyslipidemia and increased oxidative stress contribute to premature atherogenesis in these patients. Several atherogenic factors in patients with CKD have been postulated, including arterial wall injury, platelet activation and adherence, smooth muscle cell proliferation, and intraarterial accumulation of cholesterol. Lowering of serum lipids has not been shown to improve morbidity and mortality in hemodialysis patients. Furthermore, current KDIGO guidelines for lipid management in CKD do not recommend using cholesterol values to determine who to treat or as treatment targets. Currently, patient HBT is not receiving a statin which has not demonstrated the ability to reduce mortality or morbidity in dialysis. If concern with treating patient HBT's dyslipidemia persists, a moderate intensity statin may be considered. Dietary intervention successfully reduces triglyceride and cholesterol concentrations in patients with CKD5D. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 514.